Everyone. I wasn't expecting that. Hello, everyone. Thank you for spending this time with us. Um, I'm going to just share my screen with you very quickly. And here we go. Just a little bit about myself. I'm a pediatric dentist here in the Chicagoland area. My partner, Dr. Czerepak, is also on this call with us. And we are a general pediatric dental practice. Both myself and my partner, Dr. Charlie, as we call him, are on staff at the Ann and Robert H. Lurie Children's Hospital in Chicago. We actually both trained there when it was known as the Children's Memorial Hospital a long, long time ago. And so we are hospital trained pediatric dentists, and we do have a special affinity for children with special health care needs among the typical children that we see every day. I'd like to encourage you all please to ask questions. I'm happy to answer any questions you have. I know that this can be a very daunting sort of thing in terms of just everyday, practice, brushing teeth and keeping children's mouths healthy. But if we all work together, I feel really strongly that prevention is the way to go, and I hope this information will help you get there. All right, so the first little housekeeping thing, my disclosure statement: I have no financial interest in any of the products described, reviewed, evaluated. No corporate payments have been made regarding this presentation. What are my objectives? My objectives today are to discuss the physical and medical issues that can affect good dental health, to talk about the oral hygiene routines that will promote excellent dental health, the behavioral strategies that you can use to gain cooperation from your child. What are the elements of a healthy dental diet? What sorts of dental trauma might you see in your home or in your environment, and the possible ramifications of that? And then, of course, any questions you would have at the end. So, what are the characteristics of ASXL syndromes that can affect dental health? Well, these include developmental delays, behavioral challenges, and sensory issues that can make everyday routines difficult. Certainly, sensory issues can create aversions to everyday sorts of items like toothpaste. Feeding issues, which may include difficulty swallowing, difficulty controlling a bolus of food, and that can result in diets that are soft or pureed. Issues with textures of foods may also contribute to feeding issues, and these foods are typically not ideal. Soft foods are not ideal for preventing tooth decay. And in children who have difficulty regulating their blood sugar, which, as you know, can be found with the ASXL2 syndrome, these children might have to be fed more frequently, and we know that that can also increase the risk for tooth decay. Motor delays and low muscle tone can also impact not only a child's ability to brush their own teeth, but also their just walking around and ambulating, which falling can help increase the risk for dental trauma. When we go back to brushing, we know that children may want to brush their own teeth, but they're unable to do so because they don't have the motor tone. They don't have the fine motor skills to do an adequate job brushing. In addition, kids with low motor tones can sometimes have an incomplete swallow or difficulty controlling a bolus of food, and that can result in food being located along the cheeks and the gum line after meals, which again impacts the risk for tooth decay. In children who have cardiac issues, they may sometimes require pre-medication with an antibiotic prior to a dental visit. And in the event of cardiac surgery, the surgeon may ask for dental clearance prior to the surgical treatment, because they will not want any dental treatment while your child is recuperating from that surgery, and that could be for as long as 6 months. From a neurological perspective, we know that children who have seizures can have their seizure threshold lowered by stress and anxiety. We also know that children in the dental environment can become stressed and anxious. So anytime we have a child with a history of seizure activity, we have to be alert and ready to ensure the safety of that child in the event that they should have a seizure. All right, let's just do a quick overview of dentition. So we have two sets of teeth. We have our primary or baby teeth, and we have permanent teeth. The average child has 20 primary or baby teeth. This is a little eruption chart here that tells you when the baby tooth comes in, when the baby tooth is lost, and describes the name of the tooth. As I said before, the average child has 20 primary or baby teeth, with the first tooth erupting into the mouth at approximately 6 months of age. The eruption times and the eruption patterns are variable, with some babies getting their first tooth at 3 months of age, and some not until after their first birthday. The first baby tooth is usually lost from the mouth around the time that the first permanent tooth comes in, which is about 6 years of age. And this process continues until the average child is around 12 or 13 years of age. We know that children with ASXL syndromes may have a variety of dental issues, including missing teeth, extra teeth, or teeth that have an atypical shape or form, or some issue with the enamel formation. So permanent teeth over here. The average person has between 28 and 32 permanent teeth. The variability comes in with the presence of the last set of molars, which is the wisdom teeth, and they can sometimes be missing or impacted. As I said earlier, typically the first permanent tooth will erupt into the mouth at around the same time that the first baby tooth is lost, which is 6 years of age. An interesting fact is that permanent teeth start to form or develop day one of life. The day that your child is born is the day that their permanent teeth start to form in the upper and lower jaws. Any medical issues that impact your child from birth through the first 10, 12 years of their life can adversely affect the formation of permanent teeth. And that is commonly seen in disturbances of the enamel on the outside of the tooth, the crown of the tooth, or the root formation. Over here, this is just a photo of a cute little mouth with cute little baby teeth. And on this side, it's permanent teeth. Can't quite see it because of the zoom thingy, but you all know what permanent teeth look like. All right, so rule number 1, establish a daily oral hygiene routine. It is really important, really, really important to establish a brushing routine in infancy with your child. The more routine toothbrushing becomes, the easier it will be for everyone involved. Children who do not brush their teeth twice a day when they are 2 years of age will have a difficult time brushing their teeth twice a day at the age of 5 or 6, when the permanent teeth are erupting into the mouth and school schedules have started to become more routine and more demanding. So brushing twice a day from day 1 is really, really important. A question I get a lot is, when do I start brushing my child's teeth? Do I do it when they're a year old? Do I do it when they're 18 months old? When do I do it? My answer for that is the day that a tooth appears in your child's mouth is the day that your child should start getting their teeth brushed twice a day. The American Dental Association and the American Academy of Pediatric Dentistry recommend that you brush your child's tooth with a soft bristled toothbrush and a bit of fluoridated toothpaste on the day it erupts into their mouth. By a bit of toothpaste, I mean the size of a grain of rice. I always think it's a really good idea with infants after they've had a feeding, whether it's a bottle feeding or breastfeeding, just to take a warm washcloth, wrap it around your finger, do a swipe of the mouth, just so that your child gets used to having something in their mouth after a feed. What is the ideal oral hygiene routine, like gold standard? If you said to me, Nancy, I'm going to be on it, what should I do? Well, number one is to brush your child's teeth after breakfast and before bedtime daily, every single day. Floss your child's teeth when there are no longer spaces between the teeth, and that typically happens between 2.5 and 3 years of age, when the primary second molars erupt in the very back. And another super important thing is to never ever put your child to bed, either nap time or bedtime, with a sippy cup or a bottle of milk or juice or any sugared beverages. We know that when children suck from a sippy cup or from a bottle, they will maintain a bit of whatever the liquid is in the bottle around their teeth. So this photo to the left, as you look at the screen, this is just a soft bristle toothbrush. It can be used on any baby tooth. There are numerous toothbrushes for sale: Target, CVS, Walgreens, Amazon. These are little flossers that are really good for kids. Number one, they've got a nice handle for the parent to hold on to. The floss is fruit flavored, so the kids like the way that it tastes. And then when the kids get older, around 3, 3.5, maybe 4, we give them a little timer and we tell them that they brush their top teeth until all the sand is through, and then they flip it to do their bottom teeth. But as I said, that's not until they're older. And then once again, I just want to reiterate, please do not put your child down to sleep with a bottle of milk or a bottle of juice. So what does health look like? What does healthy gum tissue or gingival tissue look like? You can see in this photo, the tissue is pale pink. The tissue fills in the space between the teeth. And when these teeth are brushed, this tissue will not bleed. This is what health looks like. What does diseased tissue look like? Unhealthy gums or unhealthy gingiva are red and inflamed. So right here, this is inflammation. You can see the redness here. And when these teeth are brushed, the tissue will bleed. And you'll notice that there'll be some plaque visible on the teeth. So right here, this yellow stuff here, all through here, that's all plaque. And you'll notice that where it is where you see the redness, right there. What are some of the risk factors for gingivitis? Gingivitis is just another term for inflamed gums. The number one risk factor is inadequate or poor oral hygiene. Here's another photo. Once again, you see inflammation. The plaque here looks a little bit different. It almost looks like cottage cheese. That's what I tell the kids at the office. When you see something on your teeth that looks like cottage cheese or it looks fuzzy or furry, you need to go back in the bathroom and brush again. We know that diets that are high in processed carbohydrate or in soft foods or sticky foods will result with the food sticking along this, oops, sorry guys, sticking along the gum line here. And that will be a mechanical irritant to the gum tissue. It's sort of like when you get a sliver in your finger and you get a little localized infection or a little irritation, same sort of thing. And then there are medications. And I know that a lot of ASXL children are on a myriad of different medications. So medications can cause dry mouth. When you have a dry mouth, there are several things that happen. Number one, you don't have saliva to help cleanse the mouth. Number two, you don't have saliva to help buffer the acids that are created in the mouth. And number three, it makes it more difficult to swallow. And when you don't swallow completely, you have retained fluid in the mouth. So what are some of the medications that can cause dry mouth? Seizure medications can cause dry mouth. Allergy medications like antihistamines. ADD or ADHD medications that are stimulants can cause dry mouth. Asthma medications like albuterol can cause dry mouth. Antiemetics that are used to control vomiting, anti-anxiety agents, all of these things can cause dry mouth. And we know if you don't have enough saliva to cleanse the mouth and to help lubricate the tissue, gingivitis can occur very, very quickly. So let's switch gears a little bit now and talk about brushing strategies. What can we do, or what strategies can you employ at home to help make brushing for your child easier? Well, the number one thing we employ in the dental office is distraction. If you walk into my dental office, you will see TVs everywhere. There are TVs in front of the child. When we lay the kids back, they look up, there's another TV in the ceiling. And we do that because we know that when children are distracted, it is easier for us to get our jobs done. So there are a number of apps you can download on your phone. There are videos on YouTube. There's even, with the Oral-B toothbrushes, if you take your phone and you take a picture of the character on the toothbrush, it'll take you to a little website, and then the character will brush their teeth with your child, which the kids love, by the way. So distraction works really, really well. Demonstration. Another technique we use in the pediatric dental office. We role model on dolls. We role model on stuffed animals, or even on siblings. If you have an older sibling that you know is a good toothbrusher and will be cooperative, you can say, okay, Sammy, we're going to start on Summer first, and Summer's going to show you how we brush teeth, and then switch it over to Sammy. Or if we have a favorite stuffed animal, let's count, Lammy's teeth with our toothbrush. Let's brush Lammy's teeth. All of those things work really, really well. Children do very well with demonstration. And then encouragement. So every time a child comes into my office at the end of the appointment, we encourage them by giving them a little goodie bag, and the goodie bag has a treat in it for the child. Encouragement works really, really well with children. Positive encouragement and positive reinforcement. There are toothbrushing charts that you can, download from the internet. You can put it up. You can mark off how many, times in a week we cooperate for good brushing, and have a little, reward set up. Maybe at the end of 2 weeks, we'll go to Target or we'll go to Walgreens, and your child gets to choose a brand new toothbrush, or maybe a brand new flavor of toothpaste. You never have too many flavors of toothpaste, people, I'm telling you. But positive reinforcement. My heart always sinks when I hear a parent say to a child, now, if you don't do a good job brushing your teeth for Dr. Nancy, you're going to get cavities and it's going to hurt. That does nothing for the child. It's negative reinforcement. It gives them a bad message. And in the event that your child should get a cavity, immediately it puts the dentist behind the 8 ball, and they have another hurdle that they have to overcome. So please, negative reinforcement is not helpful to anybody. So let's talk about positioning strategies. How do you position your child so that you can be effective and do really, really adequate brushing? Well, if you can't see a tooth, you're not going to be able to brush that tooth. There is a reason that dentists all lay their patients back and position themselves to the side of the patient or behind the patient. And that is for visualization. In order to brush a tooth well, you have to be able to see it. In young children, in this photo, I have always found it best to lay your child down. You can lay them down on the floor. You can lay them down on their bed. You can lay them down on the couch. You can even just lay them back in your lap. Get behind them so that you can see all of their teeth. You can gently, with your fingers, retract their cheek to the side to get in there and brush. You can pull down their upper lip. You can pull up their upper lip, and you'll have complete visualization, and you'll be able to access the teeth and do a really good job brushing. As they get older, 2.5, 3 or 4 years old, you can actually stand behind them in the bathroom. You can see this little girl's mouth is open. Her mom has got the toothbrush right along the gum line, which is exactly where we want it. I can see the molars on the other side of her mouth. So this is a really good position for this child to be in. And it really is all in your approach to the mouth. If you're in the bathroom and you're bent over and you're trying to brush their teeth, you're not going to see half of the teeth. You're only going to see what's directly in front of you. You're not going to see what's to the side. So Positioning strategies are really important. So let's talk about the first dental visit. And when do you schedule your child's first dental visit? My answer to that is you schedule the first dental visit the minute you see a teeth erupt into your child's mouth. You may be thinking, why would I schedule a dental visit for a baby or for an infant? What could possibly happen at that visit that's going to be of any value? Well, the very first thing that's going to happen is the dentist is going to examine your child's tooth or teeth. They're going to look at the shape of your child's upper jaw. They're going to look at the shape of your child's lower jaw. They're going to extensively discuss with you your child's medical history, including their diagnosis, their surgical history, any therapies your child might be receiving, any medications that your child is taking, or any future treatment that is going to be coming up. They're going to talk about oral hygiene instructions specific to your child. They're going to talk about toothbrushing instructions specific to your child, along with the diet, along with the family's genetic history, and anything that could affect your child's risk for dental disease. When all of those things get discussed and are intentionally and thoughtfully, discussed again, you will find that you will set a course for your child to have optimal dental health. And I would argue that the first appointment is really vitally important to establish the best course forward for your child to achieve optimal oral health. All right, so we talked about how to brush. Now let's talk about the thing we're trying to avoid, and that is cavities. How do cavities form? Well, in order for a cavity to form, you actually need three things. You need a tooth, you need plaque, which is just an aggregation of bacteria, and you need a substrate or something for the plaque to eat or metabolize, and that's refined carbohydrate and sugars. So we know if the bacteria or plaque is not removed, the bacteria will metabolize the sugar that enters the mouth. That creates an acid, and with time, the acid will demineralize the tooth until you have a cavitation or a hole in the tooth. So why do we say brush our teeth twice a day? We do that because you have to remove this dental biofilm or plaque, which, as I said earlier, is just an aggregation of bacteria. If it's not removed, you can see the gum tissue here is red. Thank you, AI, for showing that. It did a really good job. And the bacteria will eat the food, and then you create an acid. The pH of the mouth drops, and over time, you have a cavity or a cavitation or a hole in the surface of the tooth. So if you look at this photo right here, this is a little one. This child is literally 14 months of age. How do I know that? Because I'm looking at the teeth in his mouth. He's got one molar here. He's got nothing behind this tooth. And you see the notching here. You can actually see the decay that's behind the tooth. This is a child that was laid down with a bottle or a sippy cup that had milk in it. We call this condition ECC, or early childhood caries. And early childhood caries occurs when a child goes to sleep with a bottle. That last bit of milk is not swallowed. It sits on the teeth. The bacteria or the plaque metabolizes that, creates an acid, and the acid slowly goes ahead and creates this cavitation. This is what cavities look like in front baby teeth. The only way to fix this is to go to the operating room at the hospital, because this is a very young child. You can't fix this in a dental office. These teeth are typically lost at around 7 years of age. So if you have a 14-month-old or an 18-month-old with something like this, you have to restore and fix the teeth. Otherwise, the tooth will go on to become infected. And behind these baby teeth, the permanent teeth are developing, which will then become problematic for the permanent teeth. This is what we're trying to avoid. All right, so let's talk about the diet a little bit. We talked about not laying down with a bottle. So let's talk about, kids' number one favorite candy in the world, and that's the gummy sticky stuff. anything that's made out of gelatin and is fruit flavored has the potential, when eaten, to get caught or trapped underneath the gum tissue. And what we know about these candies, and it doesn't matter if it's a candy or if it's a fruit leather. I have parents say to me, but Dr. Nancy, it's an organic fruit leather. It doesn't make a difference. Then you'll get organic cavities. That's all that's going to happen. But these things are trapped underneath the gum tissue. They are not soluble in saliva. The saliva will not melt it away. And it sits there for weeks on end. And over time, you slowly cavitate the tooth. We do a little science experiment with the kids when they get a little bit older. I tell them to get 2 glasses of water, to drop a gummy bear in one glass, and to drop an M&M in the other, and see how long it takes them to melt. The gummy bear will be there, for weeks. The chocolate will be melted, within a few minutes. Chocolate will clear them out, even if the child doesn't do a good job brushing. Ultra processed foods, refined carbohydrates, donuts, crackers, that sort of thing. When they enter the mouth, they become very soft, they become very sticky. You've all had the experience of, giving your kids something like, I don't know, goldfish crackers, and then they open up their mouth and you see there, can't see the shape of the goldfish cracker, you just see like orange slime everywhere. It is hard to just swallow and get rid of all of that stuff. And then, of course, we have juice and we have soda. The American Academy of Pediatrics recommends you do not give your child juice. We like kids to drink water in between meals and milk with a meal. We know that children that get in the habit of drinking juice, when they get older, they don't continue to drink juice. They switch from juice to soda. And then we have, an even bigger problem on our hands. So what kinds of snacks are actually healthy? What are what I would call tooth friendly? Any fresh fruits or vegetables, berries and citrus and grapes, sliced cucumbers, sliced carrots, red bell pepper strips. And parents will say to me, oh, but it's not portable. It's just not, well, with the myriad of containers now that you can take with you, everything from those little silicone envelope things to Rubbermaid containers. You can safely transport these things, and it's not an issue. Dairy, yogurt with fresh fruit is a great snack for children. Please read your labels. There are some yogurts that are much better. When we talk about sugar content, just sort of a quick and dirty rule is if a serving of a food item has double-digit sugars, 10 grams or more, then that's not something we want to eat. Just an easy way to remember that we want to look at the label and we want to make sure that we're not getting a lot of sugar. A little rule of thumb, 4 grams of sugar is 1 teaspoon of white sugar. So if you've got 10 grams of sugar in a yogurt, you've got 2 teaspoons of white sugar right there. That's not a good option for us. And then any cheese is also a really good option for snacking. They come in those convenient cheese sticks now. And we know that yellow cheeses in particular are good in helping to reduce the pH of the mouth, which is what dairy does so well. Okay, so if we want to look at the very best ways to lower tooth decay, good dental hygiene, a lower sugar diet, using fluoridated toothpaste. Oh, and let's talk a little bit about water. We like for children to drink fluoridated water until at least they're 12 or 13 years of age. In Chicago, where I'm located, the Chicagoland area, we have fluoride added to our municipal water supply. That is not the case everywhere. It is a legislative thing that is done in municipality by municipality. So you need to either ask your pediatrician or ask your local pediatric dentist if the water in your community is fluoridated. If it is, that's great. You don't have to think about it anymore. If it's not fluoridated, then you should either go to the grocery store and buy fluoridated water there, or if you have water delivered to your home, then you need to call the company and ask them if they have fluoridated water. Tell them you have young children in your home and you'd like for them to drink fluoridated water. The best way to lower the risk of tooth decay, honestly, is to have motivated parents. To have parents that are going to brush their kids' teeth twice a day. To have parents that, aren't going to have a lot of sticky stuff around, and just monitor things. And another thing that I want to emphasize is please do not give your children gummy vitamins. Gummy vitamins, I know they're everywhere. I know when you go to the store, there are shelves of them, and it's hard to find the chewable or the crunchy vitamins. But gummy vitamins are no different from gummy bears or Sour Patch Kids or any of that stuff. So it will result in. All right, so how do you know if your child has a cavity? You can't always see it. In fact, most of the time, until the cavity has gotten large, you're probably not going to see it. So you've got to have sort of a clue as to what's going on with your child. There might be changes in their eating behavior. They may go to put something in their mouth to eat, and then you realize, oh, they're shifting over to one side. Sometimes children will wake up during the night and say that there's something that's bothering them in their mouth. Sometimes they're just irritable, and you're not exactly sure why. Children that are nonverbal may actually hold their face, like this. That's another clue that they might be uncomfortable or have some sort of pain. The easiest way is to see a brown spot or a dark spot on a tooth. But you'll notice that doesn't, it can look different. So this is actually a cavity on this baby canine tooth. And you'll see that there's sort of like a white spot, and then in the middle of the white spot, there's this yellow area. That yellow area is actually the cavitation. If I were to take an instrument and touch that, it would penetrate the surface of the enamel, which is what the definition of a cavitation is. Down here on the bottom photo, you'll notice, once again, this is a young child, a child under the age of 5. And I know that why? Because there are no permanent teeth in this mouth. This is the upper arch or the top jaw. There are 10 baby teeth here. You see these large brown holes in these molars. Now, interestingly enough, there are cavities on the biting surface here and here, here and here. If you look, you'll see this child's teeth don't touch at all. This kid has got spaces between all of the teeth. So where did the sticky stuff stick to? The biting surfaces of the teeth. And that is what causes these big holes. Molars are typically lost when a child is 12 years old. So if I have a 4-year-old that walks in and I have a tooth that looks like this, we have to fix that tooth. Not only because we don't want the cavity to progress, we don't want the child to have pain, but orthodontically speaking, this tooth guides the permanent 6-year molars in and helps set the occlusion or the bite of the child. So you can see it's a complex issue, and it's just better to avoid the whole thing. And the photo up here, this is an advanced cavity. You can see the amount of destruction. The cavity started in between the teeth, and until it got to almost the middle of the tooth, it probably wasn't noticed by anybody, and then it cavitated. Let me say a little bit now about why these cavities can get big and then all of a sudden just cavitate like that. We do not routinely take x-rays on young children. Radiation is cumulative over time, and especially in children with special healthcare needs, we know that they get x-rays probably more than the average child. So we are judicious and we are intentional in our use of radiation in children. Unless I look in a mouth and I see something like this, I am not going to take an x-ray. And these cavities, especially the ones that come from the gummy sticky foods, start in between. And remember I said earlier, it gets underneath the gum tissue. You may not see it until you have a cavitation like that. But by then you've got, fairly complex advanced dental disease that has to be treated. So this is just a case. This is one of my patients. This little girl has special health care needs. She was very premature. She was born at 25 weeks. and came into my office when she was 2.5 years old. And her mother said to me, her smile looks funny when she smiles. Well, this little girl was she had a lot of weight issues, she had a lot of feeding issues. She was walking around with a bottle of milk all day long. And her mom said to me, I never put her to sleep with a bottle at night, but when she naps with the bottle. I didn't think that would hurt her. This child had 20 baby teeth now. Out of the 20 baby teeth, at the age of 2.5, 16 had cavities. When you can see, there are literally entire layers of the enamel that are missing. And if you look in the back, you can see these large brown areas. He went to the operating room at the hospital, had a 3.5-hour procedure, and unfortunately lost a number of these teeth. We were able to save about half of them. But, you then have issues, again, like speech and like feeding, and that's why it's so important to get started on this stuff very early on, and and to really make that first dental appointment the minute your child has a tooth out. All right, so we're going to switch gears now. We're going to talk about dental injury. And what are the contributing factors to dental injuries? Any kind of a balance issue, any kind of an ambulation issue, being in a chaotic or unsafe environment. So what do I mean by that? I mean, if there are a lot of toys around, if there's a lot of equipment in the way, if there's just a lot of distraction. And then certainly we know children with low muscle tone, if they stumble and they don't have good muscle tone, they may not have the strength that they need to kind of correct for that, and they end up falling. One of the most common injuries we see are soft tissue injuries. Abrasions, lacerations can occur to the lips, to the cheeks, to the tongue, or to the frenum. All three of these kids happened to get injured while I was on call. This little guy was running. He's a cute little guy. He was running, and he had his tongue sticking out, and he tripped and he fell, and you could see he bit right through his tongue. You can literally see the tooth mark right there. So when you have a tongue injury like this, you think, oh my God, I have to stitch that, but we really don't. We rarely stitch tongues or suture tongues. If it's through the border of the tongue, we might consider it. And that's because we don't want it to heal and have have the tongue not be one continuous group. We don't want it to be biped. So that might get a stitch, but this was not stitched, and within 48 hours you couldn't even stitch. This little one was running and did a face plant. This is called a frenum, or some people would refer to this as a lip tie. We also have frenums underneath our tongue. I'm sure you've heard of the tongue tie. And she fell, she face planted, her lip went up, she hit the floor, and she has a nice little cut right here. So this ended up getting a stitch because it was actually fairly large, even though that's really unusual. Most of the time we say just take a warm or a cold washcloth and put it up against the tissue and let it help you. The cold will help control the oozing because the blood vessels will constrict. This lip is one that requires stitching. So this area right here, where the lip stops and the skin starts, is called the vermilion border. When the laceration goes through the vermilion border, you need to put a stitch in. Otherwise, the skin won't heal properly, and you'll get a very unpleasant-looking scar. This particular incident, this child needed 2 layers of stitches because he actually cut through the muscle layer in the lip. So this is another time where it's really important to have a dental home or a dental provider that you can call so that it's not an emergent situation. You're not trying to figure out who you should call. You can call the office. You can send a photo via text, via email, and then your dental provider can instruct you on what to do next. This is something that we see in the dental office, I don't know, maybe every week, every other week. It's called luxation. Luxation is when a tooth is completely knocked out of a child's mouth. So this little guy did this on a Saturday night, and he completely knocked out this tooth right here. And he almost knocked his tooth out completely. When they called me, the very first question I asked the mom was, "Do you know where the tooth is that was knocked out completely?" She sent me this photo. And she said, "Yes, I have it right here." We asked that question because we need to know where the tooth is. We don't want the tooth to end up in the lungs of the child, to end up in their lungs. So if they start crying immediately and they inhale backwards and the tooth is in their mouth, they could aspirate the tooth into their lungs and has infected material. So that necessitates the trip to the emergency room. If they swallow the tooth, that's not such a big deal. But we need to know where the tooth is. So if a parent tells me that they can't find the tooth, they have to entertain the idea of perhaps going to the emergency room. I met them at the office. I was really concerned that this tooth was going to get aspirated. This child was really upset, so they met me at the office. I put a little numbing jelly on the gum tissue, took a gauze, and just pulled that tooth right out. It was very easy to do, not a big deal, and we didn't have to worry about whether or not that child was going to get that night without aspirating the tooth. Just so you know, we never put a baby tooth back in the mouth. Right here, the permanent teeth are forming, and we don't want to do anything that could potentially injure the forming permanent teeth. So permanent teeth we may put in, baby teeth we don't. All right, let's talk about fractures of teeth. Fractures of teeth can occur in baby teeth, like this little one here, or in permanent teeth. It can be confined to just the enamel of the tooth, or it can go all the way to the middle of the tooth and involve the nerve of the tooth. So this little one, this is a very little one. This child is about 18 months of age. And I know that because there's nothing behind the spinal incisor. He was toddling, trying to walk, fell, and he fractured the enamel right here. So what we did with this young man is I had the mom leave a little bit of toothpaste on that fracture until he was older, at about 2 or maybe 2.5. We were able to put a little bit of bonding material on there so the tooth looked like a tooth again. And then, you know what happened? A month later, he fell again and he knocked the bonding off. So we replaced it one more time. That happens all the time. And I've had parents that have just said to me, "You know what, we're not going to bond it again. He keeps falling." As long as, you know, more of the tooth isn't fractured off, it's fine. It's not a big deal. This little guy had a scooter accident. These are permanent teeth. So only the enamel is fractured here. All of this black stuff that you see on the photo is just dirt from the driveway. When they came to the office, I asked him if he spit out the fragments of his teeth. And he looked at me and said, "No, I didn't spit anything out." And so we put a little Band-Aid to cover the teeth off. I sent him to the emergency room, took an X-ray, and the tooth, you can't see it, but there's a laceration underneath it. And the tooth fragments were where they were inside the upper lip. So they called plastics, plastic surgery came, got the tooth fragments out. I saw him a couple of days later, and we fixed his teeth up for him. This guy fell. This was a sledding accident. And while this tooth is just a fracture here, you can't really see it, but there's a little red dot. That red dot is the nerve of the tooth. So this is an emergency that has to be seen right away. We have to cover up that nerve tissue. Number one, it's very painful for the child. And number two, we don't want the nerve to get infected with the bacteria that has been sitting around. So this is another situation where it's really important to have a dental home, to have someone to call that can help you. We were able to cover the nerve up. We put some medication. We bonded or we restored the tooth, and that was actually during the pandemic. And when we were shut down, and that those two teeth are absolutely fine now. So that was a good outcome. This is something you may actually have seen in your own homes. It is a baby tooth concussion. Sarah, I just looked at my watch and it's 10 minutes to 12. Is this like, am I late now?
No, you're not late. No, we do have.
I think okay. All right, I'll speed it up. You may have all seen this little guy fell. And when he looked up at his mom, he was crying. He hit the tooth, but the tooth was concussed. It wasn't luxated. It's still in the same place. You can see that there's bleeding here. And what that bleeding tells me is that the ligament that holds the tooth in place was disrupted. And it tells me that the tooth may have been moved just slightly. So when we see these teeth in the office, and this is something we see literally every single day, you know, there's very little that we do. If the tooth is really loose, we will maybe go ahead and take an X-ray to see if there's a root fracture up here. If there is a root fracture, then usually what we do is we wait a couple of weeks, we see if the tooth firms up. If it firms up, then there's nothing else that we do except for continue to follow it. These are the teeth that will sometimes turn gray or dark. I'm sure you've all been, you know, at a class or something, or someone in your child's, you know, play group or something, and they smile and they have a dark front tooth. That comes from an accident like this. We know that there's been bleeding. You can see the blood. As the tooth heals, the iron compounds in the blood actually drop into the crown of the tooth and darken it. And it's sort of like a scar. Sometimes it'll lighten up, sometimes it won't. It'll just stay dark, but the majority of these teeth exfoliate or come out on their own without any further intervention. Every single day I say there's a reason God gives us two sets of teeth. This is one of the reasons. All right, so just some closing comments. Medications, please be aware that liquid medications that are flavored for children, whether they're over the counter, Benadryl, Tylenol, Motrin, or whether they're prescription, like amoxicillin or Z-Pak, are 50% sugar by weight. So after a dose, please give your child a drink of water. If you could brush, that would be better. Please be aware that pureed and soft diets in children with feeding issues, those foods tend to stick to teeth. So try to get all of the retained food off of the teeth after every meal. The use of cavity fluoride varnish. Cavity fluoride varnish is something that not only pediatric dentists, but pediatricians can use on children's teeth. It's very easy to apply. You mix it up in a little well, you brush it on their teeth. In children that have average risk for tooth decay, we apply it 2 times a year. In children that may have higher risk for whatever reason, we can apply it up to 4 times a year. Remember, if your child has chronic or recurrent vomiting, that you don't want to brush their teeth right after they vomit. Rinse their mouth with water, wait 30 minutes, and then brush their teeth. You don't want to brush the acid into your teeth. Please, by all means, you can utilize some of the other healthcare professionals involved in your child's care, such as occupational therapists and speech therapists, to help you work on desensitizing your child to toothbrushing, to help work on oral aversions, to help modify things like toothbrushes, to get a better grip on it so that they can do a more adequate job brushing their own teeth. And it's all about prevention. Brush and floss your child's teeth twice a day, limit the sugar, and routine dental visits. I'm sorry I went so long, and I'm happy to take any questions that you may have.
Does anybody have any questions that they have? Or you can put a question in the comments if that's easier for you as well.
Let's see. I am going to stop sharing my screen. Oh, wait, no, I'll leave it up for just a minute. Let me just hit the chat box. There we go. Oh, no questions in the chat.
Okay. While we're waiting for people to share or have comments to make, stories to share, I just wanted to say thank you to Dr. Nancy. She has been Sammy's dentist since he was 2 years old, and one of the most the biggest impression that she gave me when I first came, to give you guys some context, Sammy had just gone through open heart surgery when I was 8 months pregnant with my son Shepherd, and I was 2 weeks post-op from a cesarean when I noticed a brown spot in Sam's tooth. And I had been taking him to a different dentist who did not listen to me. And so I asked Sam's heart doctor who she would recommend, and she recommended Dr. Nancy. So she's a little bit of a drive for us, but 100% worth the drive. When I showed up with my infant in his little carrier and my 2.5 month or 2.5 year old who was still recovering from open heart surgery, she looked at me and she was like, "Are you okay?" Because she was like, "Who is this crazy lady coming to my office?" But I remember she looked at me and she said, "Sarah, you take care of getting Sam to his appointments and his therapies. I will take care of his teeth." And that is what she has done. And so I think like if I could say anything to parents, shopping around and finding a dentist who listens to you and takes things seriously is everything. Because just because a dentist says, "Oh yeah, we have experience with kids with special needs," that doesn't mean that they are qualified. Truly listen to your gut, because Dr. Nancy has been that person for our family. All of my kids go to her now, and she absolutely looks at Sammy as a whole person. She doesn't just look at his mouth. She wants to know about every single thing that has happened since the last 3 months that we were there. So that's just the one thing I wanted to say. And it looks like we have a question in the chat. Caroline says, "What medication would you recommend to give a child so he's less anxious and be easier while he's at the dentist?"
That's a very good question. That's a very good question. So, I will tell you that, and every child's different, and I don't know your child, but in my practice, and I have children that are very significantly affected by various, various syndromes and various issues. I do not, my patients are not medicated when they come to my office to see me. I feel very strongly that when anytime you do any sort of sedation or anything like that, you need to have someone there that's going to do nothing but just monitor the child's respiration, their heart rate, and it's difficult enough for me to do the dentistry, and to get through everything that I need to get through, much less to do that, and also go ahead and monitor the child's respiratory rate and all of that. I think that it is the job of the dentist to try and figure out an environment or a way that this is going to work for your child. What we do is a marathon. It is not a sprint. It is not about getting one thing accomplished in one visit. It's about trying to set your child up so that they can walk into a dental office or be seen in a dental office for the rest of their life. They're going to need dental care throughout their entire lives. That doesn't go away. So it's really important that we figure out a way to make it work for your child. So we do not, and Charlie, you can jump in on this, with your experience, but our patients are not medicated when they come in for routine dental visits.
I just want to add a couple of quick things. One is I'm so impressed with the interest and the questions that people have. We don't pre-medicate for anxiety in our office. We prefer behavioral home approach, a very team-oriented, where the parents, the child, and the dentist work together. And the quick fix for oral health is awareness, good brushing, good teamwork with the team that you build around your child, and limit sugar. I mean, that's the bottom line to everything. Behaviorally, there's you know, every child has their own universe, right? And so we try to adapt to the child and work trying to find strategies that help the parents and the child have good oral health. It takes work. And I think when you were saying looking for dentists, you want a dentist with some patience, you know, who's willing to listen to you. That Sarah, you said it right on the head. In this day and age in modern healthcare, it's becoming rarer and rarer to have a healthcare provider who takes the time and listens to you. And you make that judgment. And then when you find somebody like Dr. Nancy, let people know, because she is a resource for your child. Um, every child's a flower, everyone is different. We love them all.
I will say that I know that it seems that when you go to the dental office that, you know, you've got to get through everything that is planned for that appointment. I will tell you, what you do at home is 100% more important than what we do in the dental office. If I clean Sammy Scout's teeth, they're going to be clean until that plaque that I talked about earlier forms by, you know, the next day. Brushing his teeth every morning and every night is much more important than whether or not I get his teeth brushed in the dental office 2 times a year or 3 times a year, or whatever the frequency is. And that's the one thing that parents need to understand. That what I said earlier about, you know, one of the risk factors is having a motivated parent. The brushing twice a day, limiting the sugar, which I know is hard, but that is really, you know, of vital importance in terms of your child's overall health and well-being. And, you know, we go to the operating room in our practice every single month. And believe me, we don't want to go to the operating room to fix cavities. That's not a win for anybody. Not for anybody.
Joanna?
Thank you.
Hi, I had a quick question. This is Juniper. She has ASXL3, and I'm probably Amanda would know the answer to this. I know in ASXL3, dental abnormalities, crowding of teeth, high palate are super common, and Juniper definitely has that. So my question, I don't know if it would be more for an orthodontist, but long term, how is that going to affect her and her health of her teeth? Will she need braces? I don't know whether she could even I don't know if she could have braces, like behaviorally. So that was kind of my question surrounding overcrowding of teeth and a high palate.
So I can look at her and I can see that she has a high palate. Before we talk about the orthodontic issue, let's talk about the one thing that may affect Juniper right now. How old is she?
She's 6.
She's 6. So when I look at her mouth and I see that her upper teeth are a little bit protrusive, the very first thing I worry about, honestly, Joanna, is trauma. I worry
and we've had that.
Yeah, that if she falls, that because her lips won't cover her teeth to protect them, that she may injure a tooth. So I hope that she has a dental home and a dental provider that you see, so that you have someone you can call in the event that something like that should happen. In terms of orthodontic issues, it looks like maybe her lower jaw may be back further a little bit, and her upper jaw is growing in front a little bit. So there can be some orthodontic implications. The biggest thing that we worry about when we do orthodontics is how we get compliance. And it's still too early to tell. She's only 6 years old. As she gets older, she may be able to cooperate very well. And now we have Invisalign. So are you located in the United States?
Yes, we're from Michigan.
Oh, okay. So you may be able to, find someone that might be able to do even a limited course of Invisalign on her, just to get the teeth back a little bit. But if you go to aapd.org, that's the American Academy of Pediatric Dentistry, and there's a search to find a pediatric dentist in your area. You can put in your zip code and find someone And, you know, they may be able to help you actually get started along that path. I know.
Okay, that's great. Thank you.
Yeah, Sammy is an Invisalign, and we started that when he was, how old was he, Sarah? Like 6 or 7?
Yeah, he would have almost been turning 8, so close to his
Okay.
8th
Oh, yeah.
birthday. And we did, we just did the retainers. You know, sometimes they put like those little knobs on your teeth. So
Yeah,
for
that's what
him,
my
it was
son
just
has.
the retainers. And our orthodontist gave us a trial retainer to try for 2 months to see if he would even tolerate it before we started treatment. And Sammy actually did phenomenally with it. And I think a lot of it was due to him just not having as much body awareness, almost like he wasn't aware that it was in there. So I feel like, you know, depending on how your child is, whether like if they're a sensory seeker or a sensory avoider, would play a huge role in that. So for Sam, he's a sensory seeker, so he didn't mind the retainers at all. He tolerated it beautifully. They did a really effective job. And for Sam, it wasn't so much about a line like looking cosmetic. For him, his top teeth were actually coming down and hitting his bottom teeth like this. And like now his teeth are aligned so that they don't bang into each other, but he still very much has a forward bottom jaw. Just to give you some context, perspective. I don't know what the right word is.
Yeah. Thank you, Sarah.
Of course.
Just a quick point about orthodontics. So the dentist is always evaluating cosmetic versus function, and then working with how much the child can adapt to the treatment. So in the bottom line is, if it's only cosmetic, there's not a high value to it. But if it's function, which, you know, if your teeth are not meeting together, it is, you know, then there's more of a push to do something.
Joanna, just a quick question. What kind of a cup does Juniper drink from? Does she drink from a straw cup?
She just learned how to do that school cup. Otherwise, she'll drink from a regular cup or like the 360 cup.
Okay, so you know what I would do if I were you? I would really, really encourage her to drink from the straw cup. And the reason for that is when she's drinking from the straw cup, she has to bring her lips together, close on the straw to suck up. And when she does that, she's actually putting pressure from the muscles in the lip on those upper teeth, and it could help bring them back a little bit. So,
okay, thank you.
As much as you can offer her a straw cup, that would be good. And maybe not now, but when she gets older, another thing that I do sometimes with kids, if they've got protrusive upper teeth and we're trying to bring them back, is I'll tell the parent to give them a washcloth. I'm just going to demonstrate. This is just a tissue. And I'll say, you know, have your child hold the washcloth with their lips like this. And that puts pressure on those upper teeth to try and bring them back in. They can do that when they're watching TV or when they're, you know, you're reading them a book or whatever.
One question that I have that I think would pertain to a lot of our ASXL kids are kids who are G-tube dependent. So there's a lot of oral aversion. There's a lot of aspiration risk in our kids. So what would be a priority to a parent who has a G-tube dependent child as far as dental care?
So the thing about children that are G-tube fed is they tend to get a lot of calculus on their teeth. So calculus is plaque that has hardened. The number one thing to remember is that there's never decay under calculus. So that's the good news. It can be unsightly, and we don't like for it to build up a lot around the gum tissue because that can irritate the gum tissue. So it's very important to get in with a toothbrush and to brush your child's teeth with their toothbrush. In our practice, we like to go in occasionally and do a complete and thorough debridement. And by that, I mean, we may go to the operating room of the hospital and use an ultrasonic tool and get all of the calculus out, knowing full well that it's going to come back. But if this child is going to be G-tube fed for an extended period of time, or for however long it's going to be, we don't want it to keep building up on itself. I've had kids that they literally get ledges of calculus going down the gum tissue, and it's friable. If that breaks off and they aspirate it, that's, that can become pneumonia, that can become a medical emergency. So it's important to brush the children's teeth, even if they're not getting anything by mouth. And those children also need a dental home.
Thank you. I'm just seeing the time. It's already 13 minutes past our scheduled time, so I want to be respectful of both of your schedules here, and I just appreciate both of you so much for being with us today. I know this is a real concern for a lot of families, and we'll be sharing this recording with them, and we just appreciate you both so much.
You're very welcome. Thank you for having us. And if any other questions come up afterwards, just forward them to us. We're more than happy to share information.
I will do that. Absolutely. All right. Thank you so much.
Thank you. Bye, everyone. Stay warm.
Okay.
Bye-bye.
Bye-bye.